All right, welcome. We'll get this afternoon session started. I'm Shami Mahmud from UC San Diego, and it's my pleasure to introduce my co-moderator, Manish Parikh from Columbia, and the panelists up here who are all going to do both some panelist work and some real work by presenting the best cases of the year. And so on the panel are Addo, Chadi Alraies, Dmitriy Feldman, Gerrold, Grodin, Sheila Sahni, Yader Sandoval, and Gautam Kumar. And the goal here is we're going to we have 6 cases, we have 90 minutes. So the goal is to present the case and have equal time in case discussion as case presentation. So you'll see a fair amount of interaction amongst the panelists, but I'm also hopeful that if you have questions, we're going to have time. So please feel free to bring up questions and join the interactive discussion. So to start off with, first and foremost, Dr. Manish Parikh here from Columbia, and he's going to present the no-option multi-vessel, multi-CTO case with hemodynamic support. Manish is a perfect person to do this.
All right, so welcome everybody again, a terrific CVI 2018, and let's do a case. All right, so financial disclosures. So here's a 58-year-old gentleman with a known ischemic myopathy, known ventricular tachycardia, has had a defibrillator placed. Risk factors include hypertension, hyperlipidemia, and type 2 diabetes. He's also had a prior stroke, and oh yeah, he's also HIV on heart therapy. And he presents to an outside institution with frank syncope, and a defibrillator goes off. He's then, 911 is activated. He shows up to the emergency room without CPR, actually awake with a troponin of 4. So his interrogation shows VFib, so he had sudden death, he survived. And interestingly, his history is that he had multivessel coronary disease, which was somehow elected to be treated medically up until this point. And he had a right and left heart at this outside hospital. So on arrival, this was his vitals. He was on a whole host of medications, including his antiretrovirals, and he was tachycardic. He had LVH. Now, we don't all look at 12 lead EKGs, but I think they're important to still look at. This is his 12 lead EKG. Notice that he has not lost R waves anywhere. Mm-hmm. He's got SCT wave changes, he's got atrial abnormality, and he's in sinus rhythm. Luckily, his kidneys are okay. His BNP was 4,000. And I'm going to review his right heart numbers, which were markedly elevated with a wedge of 36, with a PA-SAT of 53, and he had a pulmonary vascular resistance of 8 Wood units, which becomes important here. On his echo, he has a dimension, LVED dimension of 6.8. His LV ejection fraction is below 20. It's globally down, and his RV is also severely reduced. But luckily, he does not have severe MR. He's got moderate MR, which is functional, and no AS or AI, and he did not have an LV clot. I'm going to show you his anatomy. He had a full workup done at the outside referring institution, which revealed a PET viability, which had anterior and inferior viability, but a scar in his apex and lateral wall. And of course, this was a workup what we call surgery workup on the outside before they turned him down, which showed that he didn't have a PE and he didn't have any obstructive disease and his carotids were okay. So here's his angiogram. Variocaudal, his circ is missing. You don't see much in the anterior wall. It's got maybe a puny diagonal or ramus. So LAD is a stump. Circumflex is a stump. There's a tight left main. His right is a tight lesion proximally with a bridging collateral mid with right-to-right collaterals, dominant right. See the AICD lead. And here's an RAO. And you could clearly see that it's a CTO segment with bridging collaterals and a dominant right with a PDA. It's got no left-to-right collaterals. It's all right-to-right. So the CT surgical team at the outside hospital saw him and turned the patient down. Why? 1, because of his pulmonary vascular resistance, and 2, because of his targets, and 3, because of his ventricular function. So the interventional team at the referring hospital saw him and said, sorry, we really don't think we could help you with this. We don't think anything's going to benefit. And he was actually sent to our transplant heart failure team at Columbia for an evaluation for potentially either a transplant or a VAD or something else. And the heart failure transplant team then evaluated him, repeated an echo, repeated a right heart, got hemodynamics. And then because of his pulmonary hypertension and his pulmonary vascular resistance, which was the same, high, he was turned down now by our CT surgical program. And then the heart failure team said, I'm not sure what we could do for him except the ongoing medical therapy, which he's already presented with sudden death. What do you think you could do? Is there anything that you could help us with? So what are our options for revascularization? Patient was optimized. What kind of support device do we use? What do we go after? How do we go after it? And the other question, and this will be a debate that we'll talk about after, is do we offer any revascularization to this patient? Is this really a no-hope patient with the information you have and the angiogram you've seen? Shami, do you want to stop here, or do you want me to go over what I did?
No, I think this is a great time to stop and maybe have some conversations. And maybe one of the first ones I think is worth talking about is the whole concept of viability here. Because in point of fact, you had data that clearly demonstrated viability, but if there was lack of viability, would that change the approach? So that may be the first question. That here, this is actually a great angiogram to look at. So you look at this LAD that's occluded, but it does fill. I have to say, as far as targets go, these seem pretty decent targets from a surgical standpoint to me, but I'm not a surgeon.
Agreed.
The LV dysfunction is probably the reason that most often we see these patients getting turned down. And it's interesting, similar to your place, as our heart transplant program has gotten larger and larger, a lot of these patients are being referred to them for VAD transplant evaluation, and somewhere along the way, the revascularization option is not adequately addressed. And I would like to make one comment. This idea of medical therapy somehow being a therapeutic option in the presence of complete occlusions has always kind of bothered me. So even in CTOs, just remember that you will still have ischemia in that territory. It preserves myocardium, but complete occlusions and viable myocardium, then I'm not sure I even necessarily always believe a negative stress test and put those patients onto medical therapy. So anyway, that's an aside. Let's go back to Dmitry. What do you think? Do you need a viability study in this sort of a situation every time before you go to the next step, whether it's surgical or percutaneous revascularization?
I don't think every time you'll need it, but I think in this case, it's extremely helpful. We're dealing here with a very complex case, both from the risk factor standpoint as well as from anatomical standpoint, multiple CTOs. So as you're thinking about your revascularization strategy for very high-risk PCI, I think viability helps you to plan it out, which vessel you're going to go after and how complete of a revascularization do you want to achieve. So I think in this case, a viability is an important test.
Okay. So in general, you would favor getting a viability study. Sheila, do you think, knowing that now you have viability and the surgical turn down is already there, so we have to be thinking about some percutaneous option. Alternatively, if we think about a VAD transplant as our first line of therapy, one of the concerns I always have is you've already gone ahead and done, let's say, a VAD, and you have to go back a second time around. Is that a good way? So let's circle back. Do we want to really send such a patient to bypass surgery? Because in case LV function doesn't improve, they've already had one sternotomy, or are we better off trying to do these percutaneously?
How old was the patient again? I mean, I think it's,
58.
we always talk about this from
58.
58, so young guy, and it's ischemic disease. It's an ischemic cardiomyopathy, and so revascularization should be attempted. And that discussion in this patient involves a surgeon. So you can't get away with the fact that you might, if you had a surgeon that was willing to take this case, despite the pulmonary pressures, he is going to have a sternotomy. That being said, that's why these discussions are always done with heart failure. So typically they are turned down, but yeah, you are facing the risk of a sternotomy plus a VAD.
Okay. Gautam, the PA pressures are elevated, but the wedge was 36, so a lot of this is probably left-sided and driven. So if you're going to do percutaneous revascularization, what approach are you thinking about?
I think, given the fact that a lot of this is likely elevated left ventricular pressures, I think I would definitely consider mechanical circulatory support here, possibly with the impeller device, given the magnitude of the reduction in EF and potentially the need for a long procedure given almost CTO-type morphology of a lot of these lesions. In fact, CTO-type morphology. Potentially there may be a little dot of calcium there that might even require some atherectomy there as well. So given all of that, an impeller CP to maximize mechanical circulatory support that's available would probably be the best option. And maybe reasonable to evaluate whether the legs are a good option for that and the iliacs are a good option for that at this point. And if that's not a good option, if the iliacs are not great, then you might want to think about other options like subclavian access for the impeller, or like we saw, which is also not without issues. You might start thinking about other options or other forms of mechanical circulatory support.
Would anybody on the panel consider tandem and/or ECMO rather than impeller CP for revascularization?
I would say ECMO going to increase your LV-EDP, so it's already elevated, so probably that's going to be the best option. I think impeller in this case will be a more favorable option, given the elevated EDP and also the having the leg being favorable in terms of size and calcification. Especially if we look at the heart, it's very calcified. I don't think we'll find a very clean iliacs. So we have to keep in mind the alternative access as well, either transcaval or axillary, as Dr. Kumar mentioned. But ECMO will be a more burden on the LV and will be not too much perfusing the coronary in this case.
Manish, what were your thoughts?
So I think these were terrific discussion points. The issue of mechanical support is a non-starter. You need mechanical support in this case. He was optimized, but you need certainly left ventricular mechanical support. The question I have for the panel is, do you need right ventricular mechanical support as well, knowing what you know from the echo with severe RV dysfunction and with pulmonary vascular resistance that's quite elevated? And that's what I actually really grappled over. Shami, your thoughts on what you would do in a case like this?
Yeah, it's a great question. I don't think I would upfront plan on biventricular support, but I would like to see after left ventricular support what happens. And I would be ready to place right ventricular support before the intervention in case once LV support was placed. Because on occasion, if the RV is really failing, then all that happens with LV support is the situation actually gets worse rather than better. And so that's the approach I would take.
Absolutely where I was hoping the discussion went. Shami brought this up, is what type of support devices. And again, there's no role here for a balloon pump or ECMO up front. I think really your options are the impeller CP, whether it be just left or right. And I think the decision for right ventricular support will depend on on how the patient behaves and what the right heart pressures are the day you're going to do this. And also tandem is an option as well, if that's something that you do in your lab. So here's the opening hemodynamics after a lot of debate and discussion on the day of the procedure. His heart rate's 100. His PA is 35 over, actually this is a mistake. This wedge was like 30 on the day of the procedure. His PA sat was 53. And so a left-sided impeller was put in. I was ready for right-sided impeller if I needed. And just to go back, I started with the right coronary. It's a femoral case. I had a runoff. His iliacs were fine. Okay, he did not have severe disease, because that would have been an issue, as Gautam, you pointed out. So bifemoral, left with a CP device, the right with this is either a 7 or 8. I think I used an 8 French long sheath. This is a bright tip that we typically use. The 7 French JR4. This was very easily cannulated with a soft wire and a support catheter. And then subsequently, I dilated and stented this, and we used imaging in all these. So this was 2 drug-eluting stents. Didn't flinch during the CTO of the right coronary. You see how big this right coronary is. It's an important right. It's got many branches for the posterolateral and the PDA. Here, we take care of the CTO. We don't chase all this down here. This is not something that I want to do today or the day, and this is sufficient as a result for the right coronary. Now, we're not done. He's doing very well. You're monitoring his hemodynamics the entire time. He's stable. He is not intubated. He's comfortable, but it's conscious sedation. So our plan here was to take care of what was viable, and that viability was anterior septal and not lateral. So no matter how much the circ looks enticing, you got to take care of the left main and the LAD system. Bottom line was I parked my first wire in the diag to give myself room. I also wired the circ because I don't want to lose it. I dilated the left main because that was tight. And then once I had support and dilatation of the left main, I went after the LAD. This is an LP with a Pilot 200 that very quickly crossed. You see it on the right panel, sort of a fluorosave. Subsequently, I swap out wires. I don't use hydrophilic wires. To do my procedure, switched out for a wiggle wire. And then you dilate. This is angioplasty. Imaging is critical. You see that first, that diag up top. Okay, I want to keep this provisional. I don't want to make this a full metal jacket here. This is a very diffusely diseased diag. Whole point is to keep it open, but really take care of the left main and LAD and know where to start and stop based on your imaging. So IVUS becomes critical. Make sure that I keep the circ patent, but don't chase it. Here's the imaging, and I saved the imaging runs because they're very long and cumbersome. But 2 everolimus-eluting, drug-eluting stents. Then rewire the diagonal and make sure that you keep that open. Finish the left main with a proximal optimization technique. And like Shami said, this is a nice LAD. I mean, why a surgeon wouldn't want to put a graft on this is unclear, but that's what had happened. So you've got now the left main revascularized with an MLA that's over 8. The entire LAD prox to mid is bigger than 6. You've got the diag that stayed open. Again, here, hemodynamically, he has not flinched. Try not to go after anything else because nothing else is viable. And look at his post-PCI hemodynamics. Wedge is down, PA sat's up, cardiac index is up, his PVR is down. Okay, and again, he is comfortable, he has not desatted, he is not on pressors, and here we always remove the impella if we don't need it. We always do a completion angiogram here with a crossover technique to make sure this was pre-closed so that we took out the impella pre-closed and made sure that he had a stable groin. All sheaths were removed. I left his swan in for 24 to 48 hours. The labs remain stable. Now this, just so you know, this is not yesterday or last week. This was 8 months ago. This guy's ejection fraction is 30%. He's class 2, and he's doing everything he wants to do back in the borough of Staten Island where he came from and is quite happy. So I think that these types of cases at times will fall in your lap. I think the discussions were appropriate, knowing that it was viable. The CTO aspect, the technical aspect of it is relatively straightforward. It's a matter of making the decisions and making the effort to say yes and go ahead and completing the procedure. Thank you.
So that's how a master operator does it, and I want to really commend 2 other points that you should take away. First, doing the right coronary so that actually makes your left-sided intervention a little safer. Second, when you have bifurcation disease and you're dealing with a very complex anatomy, the goal is not to start chasing all these side branches and end up with multiple bifurcation stents. So the provisional approach is really the way to go. And at some point down the road, if you have to come back, you can focus on the distal right, you can focus on some of these diagonals, and over time, figure out if more intervention needs to be done. Great case. So we move on to our next case, which is so close yet so far away, Gautam Kumar.
Thank you very much. And thank you all very much for being here. Thanks for having me as well. So this is a 68-year-old gentleman who presented with acute chest pain and dyspnea to our emergency room at the VA. He had recent admission to an outside hospital in the past 10 days for very similar symptoms. They didn't do a cath on him because he had severe contrast allergy in the 1980s, presumably with ionic contrast media at that point in time, but they had never really pushed that issue with him to get him recathed. His EF was 30% at the outside hospital. 6 months ago, he had a normal ejection fraction. He had elevated cardiac biomarkers, this is still the outside hospital admission, and dyspnea, and was diagnosed with pneumonia and was treated with levofloxacin and doxycycline. His past medical history is diabetes, hypertension, hyperlipidemia, PAD with a left fem-fem bypass, lap chole 20 years ago with unreducible umbilical hernia that's been there for the last 10 years. Why this is important will come up later. Infrarenal AAA, 3.2 centimeters. His blood pressure when I saw him in the ER was 90 on 60, heart rate was 88, respiratory rate was 20, cool extremities, elevated JVP up in his earlobes, soft S1, no murmurs, bilateral crackles, increased work of breathing. On BiPAP, he looks comfortable. Without the BiPAP, his SATs drop, and it doesn't look good. And the umbilical hernia is noted, which was not tender at that point. This is his ECG. And again, you can see this is a ischemic ECG with ST segment depressions laterally. All those are new. None of that is old. And maybe even a hint, small hint of ST elevation in AVR, if you would grant me that. This is his chest X-ray. As you can see, it's very consistent with bilateral pneumonia. Not. Yeah, I love that one. Beautiful curly B line here. Definitely not consistent with bilateral pneumonia. This is his troponin. His labs start coming back. Troponin of 11, which is again newly elevated. They trended his troponins down all the way to 0.08 at the outside hospital before they sent him home. His white count was elevated. It was elevated in the previous admission too. Again, that makes people think, oh, this is pneumonia. His lactate was 2.9. His BNP was 1600, and that's his ABG. So the working diagnosis that we had was, oh, maybe this is bilateral pneumonia again. Or maybe this is pulmonary edema with cardiogenic shock. Or is this something else? So my hypothesis was that this is a non-STEMI with cardiogenic shock, with elevated lactate. His blood pressure had actually been 70 millimeters mercury before they gave him some fluids and put him on a little bit of dopamine and acute pulmonary edema. I brought him up to the Cath Lab emergently. At that point, when I arrived, I said, let's just stop here, get consent for intubation, mechanical circulatory support, all of the above. So we did all of that in the Cath Lab. He had no family. And this is his angiogram. And everybody will look at the injections to the left and say, Dr. Kumar, that injection sucks. You're a very bad angiographer. These were all terribly damped. We weren't getting much better pictures. So, Shami, you want to take some discussion now, or you want me to just move on? Because we're running a little late.
Why don't we move on and then...
Perfect. So we had, there wasn't really a whole lot of time given this presentation to call the surgeon, so I called my chief of cardiology and another cardiologist who was there. Surgeons were not available at that point to actually come down and have a serious discussion. We decided to go ahead with mechanical circulatory support and complex PCI. This is the left main ostium. With the eagle eye IVUS catheter through it, there was hypotension. When we moved the catheter back, this was resolved. I think this was a point brought up on one of the earlier live cases. And the MLA there was 3.0, which is probably underestimated because we're probably missing the true ostium even in our measurement. This is his iliacs. We managed to get an impeller through there and had a Judkins left 3.5 guide. So the first order of business here was we decided to go ahead, secure the circ. We stented the proximal circ with a 4.0 by 15 Zions. And if you take a picture, the mid circ didn't look that hot at that point, so I went ahead to go ahead and stent that with the 3.0 by 15 Zions there, and that took care of the circumflex, which then left us with the issue of the ostial left main and the LAD.
It took a 1.75 millimeter burr, 155 RPM. We did 4 runs. And this was following atherectomy and pre-dilation. We then placed 3 stents there, 3.0, 3.5, and 4.0. And post-dilated all of these beautifully, did a pot, and did a nice final kissing balloon. And this was our final result. Beautiful result, MSA 16.6. I don't think anyone will fault this result here. So I was delighted and very happy about everything and how things had gone. We transferred the patient to the ICU with the impeller in situ. He had some bleeding around the peel-away sheath, which required a couple of units of blood, and then that settled. His lactate normalized nicely. Over the next 30 hours, his blood pressure actually went up to 150 mercury. His urine output increased. We were able to wean off the impeller. His creatinine actually went down from 1.3 to 0.7. He was extubated the next day after passing spontaneous breathing trial. That's about 3 days post-procedure. After extubation, about 6 hours later, he says, "Oh, I'm having some stomach pain. It's not in the chest, it's in the stomach." We obtained a stat CT abdomen pelvis, and that is shown right here. This is the real image. I didn't just pull a textbook image. As you can see, the stranding of fat in that loop, which was concerning for a strangulated hernia. We referred him to to general surgery that recommended immediate laparotomy and cessation of DAPT and administration of platelets. A family discussion was had at that point. They and the patient all elected to withdraw care. He was discharged to the home hospice in 48 hours per his wishes. So what I came up with was, this was a difficult scenario with a complex patient with multi-system disease. The best of efforts can be stymied by an unexpected turn of events. And finally, I wanted to present this because this was my best case of the year, because it was a great moment in terms of humility. Thank you.
Well, it's a great case, and again, highlights sometimes you can get tremendous, what I would say is technical and clinical PCI success, and then you have something unexpected. And one of the issues with cases like this, of course, is this ends up being a PCI death, which is we won't have time to talk about it, but that's a separate topic that's very, very important, that somehow we need to sort out how to differentiate this PCI-related death from an elective PCI. But one question I did have, it's a technical question. I'm curious what Manish and everybody else on the panel would do. When I have ostial left main disease, sometimes I treat that first and then treat distally, contrary to what we generally like to treat distal and work towards more proximal disease. So here with the left dominant system, it can get very tricky. So sometimes I'll treat that ostium and then do the rest of the case. I'm just curious what others would do.
Yeah, so a good point. I think the key is, as you saw just with the IVUS, he had hypotension. And I think this is totally a just case. This is a shock case. So in New York, finally we have actually this, shock patients are not excluded for mortality hits. They're separated based on hemodynamics, which took a long time coming. But we do have that now. But yes, it is I would have probably done what you said, which is to put a nice stent in the left main and secured it. I think Gautam did that, basically pre-dilated and then secured just so that he could deep throat. Because oftentimes you'll get a longitudinal compression of ostial left main stents when you're working, especially because he had to roto distally. And so unless you're going to use a guide liner and not have to keep traversing that left main. So if you dilate and can stabilize the patient, so be it, that's fine. Otherwise, you need to treat that up front. So
We had to rotor the ostium itself. The ostium itself was calcified. That's a problem.
Yeah.
Yeah.
If you rotor before, there was a risk that will occlude the circuit.
Again, the teaching for rotational atherectomy is that it doesn't, counterintuitive, but it doesn't increase your snow plowing or loss of side branches. It actually facilitates because of differential plaque modification. Here in this case, he treated the circ first, and that was fine, and it was a nice job doing that. I guess you prepped it and then stented it, and if it goes, it goes. But otherwise, you need to start with what you need to start with. You cannot do this case without mechanical support.
Absolutely.
In a left dominant system, I would have had at least everything ready.
I actually had a
venous.
pacemaker on the table ready to go.
I think the point for everybody is routine pacemaker with atherectomy is associated with more bleeding when you're trying to get venous access. In these cases, I nowadays don't worry about getting femoral venous access. I get neck access to eliminate that risk. All right, why don't we keep moving forward? We want to stay on time. I think Chadi's next, Alraies. He's going to present a case of left main perforation.
All right. Thanks for having me. Thanks for the panel. My name is Chadi Alraies. I'm the interventional chip fellow at Detroit Medical Center. I made some changes to my best case of the year to my best save of the year, if you don't mind. All right, I have no disclosures. Patient is a 62-year-old man presented with chest pain at outside hospital. He has a history of hypertension, diabetes, COPD. He's in home O2, 2 to 4 liters, CKD with creatinine 1.8, active smoker. In terms of his PAD disease, he has severe PAD with FIM and FIM-POP bypass in 2016. When he presented to the outside hospital, he had a chronic limb ischemia and had a thrombosed bypass to his leg. So what they did thrombectomy there, and on post-op day 4, he developed chest pressure. This is EKG on when he had chest pain. As you see, there's some dynamic, subtle ST changes, but troponin came back of 3.4. Angiogram done radially at outside hospital. Unfortunately, I don't have too many images. This is taken from the CD. As illustrated here, you see calcified before the contrast filled the RCA. There's calcified RCA with tight lesion in the mid-segment in the 80% range. In terms of left main, it's again trifurcate into RCA, it's into a circ, ramus intermedius, and LAD. LAD is subtotaled and severely calcified, and there is trifurcation lesion at the distal left main. So the patient was transferred to us for further management, and we had a surgery, heart team approach. Going over the comorbidities, he has 3-vessel disease with left main. He has severe PAD, and the vascular surgeon said, don't touch the legs. Has severe COPD, FEV1 came back at 20. LV ejection fraction on echo was 45%, EDP 22, STS score 10, syntax score 33. And the surgeon said, with these comorbidities, we cannot take him for surgery. And he was referred for high-risk PCI. Just planning for the procedure, giving his hemodynamics, I will show you before we did it. They didn't do right heart cath in outside hospital, and left main intervention probably going to require mechanical support. Severe PAD, probably going to go radial first for everything, which can be challenging. And severe PAD, alternative access for large bore access and large bore sheath, given the legs are really not in good shape. Calcified left main, it need atherectomy, and keeping in mind he has creatinine is 1.8. So in terms of large bore, I mean, we have 2 options. This is not the patient images, fortunately, but again, this doesn't look even better. You have 2 options. Either we go transcaval or to go transaxillary. But we have some pros and cons to the transcaval. It has accommodate large bore. It can bypass the calcification, but technically challenging and requires CT planning, which is another contrast load to the patient. So therefore, probably not going to be in his favor. In terms of axillary, it has a steep learning curve, but it is considered kind of faster, require less planning in terms of CT, and can be used for emergent procedure. The cons of it is it's a 6 millimeter vessel, and if it is does not take 5 liters ampulla, which is we don't need in this case. So the anatomy is you divide axillary to 1, 2, and 3 segments, and our aim was to aim for that segment between the axillary artery between the 2nd and 3rd segment, which is just lateral to teres minor. This is again the landmarks. It's favorable in this area to stick the axillary artery. It's because it's compressible in case you fail and there's bleeding. It's far from the brachial plexus, so neuropathy is less and low risk for pneumothorax. So back to the patient, going through the left brachial vein, we did the right heart cath showing index of 2.4, output of 4.7. RV filling pressure were not bad, but PA pressure were 45 and 28 and EDP 22. So again, going through the right radial axis, we Doing an angiogram, 6 French was gained, and after that we did a Rabi that did an angiogram just to confirm the appropriate the vessels. As you see, there's some diffuse disease, but nothing flow limiting. Again, after getting the access, we advanced a stiff wire, and over the stiff wire, advanced a large sheath, which is a 14 French sheath and pillar sheath. And after that, the pillar and pillar wire go over through the MP to the LV and advance the Ampilla. After gaining positioning, this is the angiogram, and our strategy is to go, as everybody alluded earlier, to be simple. You have a very calcified left main and also subtotal LAD, so provisional was our strategy. And if we require some kissing balloon at the end with many we'll do it at the end. So this is the left main. We did several ballooning for the left main, but did not change. So we exchanged over a microcatheter from a ProWater to Viper wire, and we advanced a coronary CSI to 1.25 millimeter, and we did a couple of passes. Atherectomy was done, and this was the following image. I'll let it loop for a little bit. So you see there's a big mushroom coming up from the left main. So obviously this is...
So hold off there, Shandy, for a second.
Yeah.
So let's talk about this. First, the approach to a distal left main bifurcation. I heard Chadi say a provisional approach rather than a, say, a DK crush, which I think at this point the data for the distal left main really is in favor of that approach. So unless the side branch has essentially no disease, I think DK crush would be the optimal approach. Having said that, there's a ramus here as well, so that further confounds that issue. So first, let me ask that question of the panel. Manish, how do you approach it?
Yeah, I mean, I think, again, I haven't seen an LAO caudal view and don't really have a good assessment of what the origin of the circ looks like. But, clearly, I mean, here, this is sort of a challenging case with a lot of downstream disease as well and severe calcification. So, I mean, if you're going to use a two-stent strategy, there are many. DK crush is probably the more data-driven two-stent strategy. But again, if you're going to try to just piece this together and quickly get the left main done, a provisional approach is okay if the origin of your circ is not severely diseased. Otherwise, it's not the optimal therapy for this particular patient.
Dmitry?
Yeah, no, I absolutely agree. I think here, especially since we haven't seen some of the caudal views and don't have a good idea about the origin of the circ, I think imaging would be extremely helpful. I think imaging into the LAD and circumflex and identifying how much calcium or how much disease you have at each ostia can help you to make that decision whether you're going to go DK crush or you're going to do one stent technique.
So I think that's an important distal left main differentiator. If we know the side branch ostium is simple, not severely calcified, not severely diseased, then a provisional works great, and imaging can be very, very valuable. So looking at this left main, as bad as that looks, if I'm going to have a left main perforation, this is one I actually like. And so again, maybe Gautam, you can tackle that, or other people on the panel. What's your thought about this particular perforation? Why do you think it happened, and what's the approach you would take at this moment?
So, Chadi and Shami, I think this is a guide perforation. This is not an atherectomy perforation. Looking at the location, if you look at the tip of the guide, it is right into where that perforation happened. I mean, it's hard to be 100% sure, but this looks like a guide perforation. In any case, it's a perforation. I think the most important thing is to, in this case, tamponading this is probably not going to be straightforward. But I think first thing would be to try and get a balloon in there, get a pericardiocentesis tray ready, and start finding out where your covered stents are. Because that is a fairly big perforation. I'm not sure it is going to seal with just balloon tamponade. Thoughts, Dale?
Yeah, I agree. And, it's really helpful that we have hemodynamic support here, because without that, there's just no coming back. But yes, a large balloon, hopefully you have a large guide, so you need a large balloon to quickly occlude flow. You'll be occluding flow down the entire left coronary tree, but that's where the hemodynamic support here helps you, at least until you can then assemble additional tools to help correct this.
And I think radial first is generally a good idea, but when you know that you're going to be tackling a left main, especially planning DK crush, even though you can get away with 6 French, you do need very frequently, including this case, a larger guide, and so planning in advance would be key.
I think it's also important to highlight maybe a little bit more about your atherectomy. If you go too fast with orbital atherectomy, or if you go on the high speed, you're more prone to perforation. Can you talk a little bit about what speeds you used?
Yeah, so I think the technical aspects are important, and maybe Chadi can comment on that a little bit. The other part, as I'm noting where this perforation is headed, it's hard to know if it's really into the pericardial space. It almost looks like it's somehow ending up in a different vascular bed. Too fast to sort that out quickly. And guide catheter tip dissections certainly could look like that, and potentially perforations could as well. So you got to get rapid control of this.
So the speed was at 120, but one of the issue that happened, this happened in July, is we turned off the CSI in the guide. So before going out, I think this is one of the, going in retrospect, thinking about it, so the CSI just jumped out as like a bullet and basically kind of perfed the left main. But again, we think it's due to CSI because the engagement was fine, the first picture was okay, but I think it's mainly CSI driven.
So rather than saying CSI driven, I would say probably atherectomy driven, and it occurs with both devices,
Yes,
which is,
exactly.
it can have a lot of stored tension.
Yeah.
So you want to make sure you don't activate either of these two, rotational atherectomy or orbital atherectomy, in your guide catheter. You got to get out of the guide catheter, preferably a centimeter plus proximal to the lesion that you're trying to treat, and just a gentle tap, and you'll see that it'll jump forward about that centimeter or whatever the stored tension is. If you activate in the guide catheter and you don't relieve that stored tension, when it comes out, it can come out, and if it's up against a wall, it can cause that damage.
So going forward with the case, the left main was worked quickly with another pro water, and then balloon 3.0 by 20 was inflated. As you see, there's still a leak coming out. It's probably from LS score from 3 down to on the right side to 2, but still there is pure flow coming out into the left main. This is to confirm that this is going to the pericardium. So during that time, as you see, it's going to be a panic moment where anesthesia was called, surgery was called, patient fully anticoagulated, ACT is 256 because of the impella for sure. We cannot reverse him at this point. And the pericardiocentesis kit was brought to the bedside quickly. So again, this is the point we mentioned, echo confirmed at the bedside quickly, but again, we have enough angiographic evidence, and the fluid was wide open, and the impella was at full power. Again, after inflation for higher pressure, continue to see some mildly sealed perforation, but again, we need an ultimate therapy for this perforation. So Graft Master were brought to the room. It's a 4.0 by 16. After multiple positioning, without, as we know, we have some circ coming out and ramus without compromising the branches. It was inflated at 16 and then brought proximally and inflated at 18 ATMs for 32 seconds. And again, we're glad we have hemodynamic support, otherwise that will be unfeasible. This is kind of the sealed, after finishing the sealed Graft Master, seeing there's no perforation, and distally there is the LAD, again showing his disease, but there is no osteal compromise to the circ, ramus, or the LAD. This is final angiogram because the patient was left, he was intubated. This is final angiogram just to make sure distal to the access point there is perfusion. Patient admitted to the CCU, low dose level fed, and we did auto transfusion on the bedside. So what we did is we got a large 8 French sheath into the femoral vein, and we start doing auto transfusion with 60 cc syringe with a 3-way valve by sucking blood from the pericardium, putting it back to the venous. So the hemoglobin was probably when he came to the Cath Lab was 11.2, and when he left was 9.7 on the CCU. Effusion, again, was not detected on serial echocardiogram, and this is after 24 hours, was a small effusion, and the ampulla was removed the next day. So in terms of take-home messages, as most of us has already alluded to, is alternative access for large bore is for severe PAD this is one of the options. In this case, for ostial calcified lesion is passing and treating probably on the way back. Probably it's more safer, but Dr. Parikh and Dr. Mahmud mentioned is probably advancing distal by 1 centimeter and then turning on low speed and going slowly, and target for treating that lesion going backward more than going forward. Radial first, I mean, again, we finished the case with a radial access. There was, despite these issues, and the CTO card is very important. So to make sure you have a precardiocentesis kit and you have a cover stent that is not expired. Thank you so much.
So, Chadi, did you end up imaging this at the end after you got control? Just to make sure that everything is expanded.
Sorry, I mentioned to do it, but I couldn't pull the images from the IVAS machine, but it was well opposed and there was no kind of leaking around the Graft Master.
And of course, there's a ton of LAD disease beyond that. That's going to be for another day, hopefully, if
So this
and when he
happened
recovers and needs it.
Exactly. So this has happened earlier this month, early July.
Okay, great.
Just a quick question for the panel. I know that we prefer atherectomy when we can do it for calcified lesions, but for an osteal lesion like this, how about the use of just high-pressure cutting balloons, high-pressure non-compliant balloons to reduce this risk we've seen?
Well, this was really a distal left main disease, and so and not an osteal per se. And I would say if you have circumferential or 270-degree arc of calcification or greater, cutting balloon, if anything, increases your risk of vessel perforation because the calcified area does not yield, so the only area that can yield is the non-calcified. So I would say if you use imaging and you've demonstrated severe calcification, then don't see if you can get away with it. Treat with atherectomy up front. And this particular case was more of a technical, I would not blame atherectomy. I think these things happen when you don't pay attention to some of the technical details. The other point I should make is if this perforation involves the distal left main and you have to put a covered stent from the left main into the LAD, let's say, and you think you're potentially compromising the circ, you can use a Confianza Pro 12 and actually go through the covered stent. You know where the circ is, and you can go in that direction and open that up, and we've done that successfully in the past. So the fine point there is you want to make sure, as long as the perforation wasn't right at that point of where the osteal circ is, you can still preserve your circ and use a covered stent even for a distal left main perf.
Okay, so I think that was a great save. Congratulations, but I think there's things that we learn from these types of cases, and I think I agree, Tayo. I mean, if the imaging didn't show circumferential calcium, I would not have pulled out the CSI. But again, it's all about knowing what you're treating. Let's move on. We have the next case, which is Ischemic Conundrums in the Cath Lab, titled "To Stent or Not to Stent." Dr. Sandoval.
Yeah, thank you for inviting me to speak. We're going to shift gears a little bit to some of the ischemic conundrums in the Cath Lab, some issues that I think have become increasingly common with some of the tools that we have now in the Cath Lab. So this is a case from a few months ago, middle-aged woman with dyspnea on exertion, intermittent chest discomfort, and 2 antigenitals. She has chronic atrial fibrillation and anticoagulation with rivaroxaban. She has hypertension, obstructive sleep apnea. Because of her symptoms, she was risk stratified with a myocardial perfusion imaging study that was equivocal with question of either artifact and diaphragmatic attenuation versus possible small to moderate reversible perfusion defect and a normal ejection fraction. So based on her equivocal study and symptoms and 2 antigenitals, we proceeded with diagnostic angiography. This is right radial coronary angiography, and you can see here the right coronary artery with a lesion right where that marginal comes off. And this is the left coronary artery system. You can appreciate some diffuse disease in the proximal LAD. There is a middle LAD lesion right past that diagonal, and also there appears to be on the right, a little bit foreshortened, but there's some at least intermediate osteoproximal circumflex disease. So based on this anatomy, I guess I'll ask the panel, what should we do? Is it you say 3-vessel disease? Think about surgical revascularization. Think about single vessel versus multi-vessel PCI, medical therapy, or more testing. We'll be presenting your thoughts.
All right, Sheila, so this is your patient. What do you want to do?
I would perform FFR about at least, I mean, I think the LAD is clear. I would perform FFR of the RCA to start. And I think we need maybe I do a steep apicaudal of the circ just to outline that ostium and then make a decision about FFR in the circ.
So clearly some ambiguity in the circ. I'm not sure about the right, but yes, I mean, you'd be surprised. And so you really want to know what's physiologically significant yet in this particular case before you relegate somebody to cabbage, not needing it. Dmitry, what are your thoughts? How would you do this?
Yeah, no, I absolutely agree. I think here, not so much the actual syntax score, but the functional syntax score is what you want to know. So I would definitely interrogate both I would interrogate all of them, the LAD, the RCA, and the osteal circ, and see where the numbers are.
Shami, should we be doing IFR or FFR on these?
Maybe the combination therapy. So let me start one step back, which would be, for patients like this, consider CT-FFR so that you can actually avoid an invasive study. So that's a possibility. But if you're on the cath table, I almost always end up using, Manish, both IFR and FFR. And I think I would remind everybody, 0.81 FFR versus 0.79 FFR, even though the data was on that 0.8 cut point, it's never that dichotomous. And the reason I like to get both IFR and FFR is I like consistency of data. And so if you have a questionable story, moderate lesions, moderate result on your equivocal result on one of those two, then I really need more information. But if they're all consistent in a single direction, that just gives you more validity. So I generally do both, IFR and FFR, in this day and age.
Right. Yep, so that's exactly what we were thinking. We said equivocal, non-invasive study, we need more testing. So we proceeded with IFR, and as Dr. Feldman said, we did IFR of the 3 vessels. This is, again, atrial fibrillation. You can see the irregular R to R. It takes 5 beats with IFR, and you can see an IFR of the right of 0.97, IFR 1.0 on the circ, and an IFR in the LAD that was repeated a couple times, which was 0.94 and 0.93 being the lowest value. So the question is, again, what do we do? Are we done? Send the patient home, medical therapy, borderline LAD IFR with equivocal study, and as Dr. Mahmud was saying, do more testing, do of FFR, or just stop debating, let's fix the one that looks the worst and that also had that equivocal anterior ischemia. Any thoughts?
Can I ask a question to the panel? Like, if we have an MPI that's suggesting ischemia pre-cath, do we need to do another physiology study during the angiogram?
So, again, I think if there's concern about discordance or if there's some thought about unreliability, then yes, I would not have IFR'd the LAD at all. And if I was going to do the LAD and if it was equivocal, I would have done FFR. What I really wanted to know was the circ. So the only thing I was going to do is the circ. I don't have the patience to IFR all 3 vessels, frankly. Now, having said that, I am exceptionally uncomfortable with a lot of the non-invasive nuclear testing that we get. So this is an adjunct. So I would have treated the LAD, or if I got this, FFR the LAD.
Yeah, and I think that,
I was just going to add, patient history and optimal medical therapy prior to the Cath Lab is a critical aspect of this. If you've got somebody who's clearly symptomatic on good medical therapy with anterior ischemia, then maybe the other lesions you can interrogate just to make a decision of multivessel revascularization versus what you think is the culprit. And this 0.93, if somebody's symptomatic on 3 antianginals, means very differently to me than someone who has that questionable chest pain and is on no drugs or on 1 antianginal.
When I found myself in this situation with the IFR being positive, when you have the ischemia on the nuke and the lesion looking like this, and the patient's symptomatic on the table, I have converted to FFR, and then I've done it just like in the trials, you know, good technique, giving nitro before and watching and comparing them, and that's helped.
Yeah, I think those are all good points. And just to clarify again, this is a patient that does not have definite anginal symptoms, has some shortness of breath. This is a equivocal study, and I should have added the images, but it was truly equivocal, so that's the reason we did the full coronary physiology. And again, at this point, we said, let's get more information. So we went ahead and we did an FFR of the LAD, dropped a little bit the blood pressure. You can see the irregular rhythm in the context of the atrial fibrillation, gave some nitro, disengaged the guide, got rid of contrast on the guide as well, removed the introducer, and this is an FFR of 0.75. So I think it becomes a little bit more clear.
So did you do the CFR as well?
Great question. We did not. So so now the question is what to fix, right? So we have the discordance IFR LAD 0.93 and the IV adenosine FFR of 0.75. And clearly this looks like the worst lesion, but there's some proximal disease. So after a pullback, the clear step up, at least with the IFR, was at this particular spot. So we went ahead, took care of that. We placed a 2.75 by 16 millimeter drug-eluting stent, had a nice result. So now the question is, are we done? Let's go home. I don't like the proximal disease, pass me another stent, or let's do a quick post-PCI FFR. Any thoughts from the panel?
Yeah, this calls for more FFR. Now that you've relieved the distal lesion, you have more blood flow going down the artery, and so there are cases where you don't have a positive FFR proximally.
Yep. So that's exactly what we did. We did a post-PCI adenosine FFR, it's 0.73. So we went ahead and we placed a 3.0 by 32 drug-eluting stent. And after that, this is our final result, and that showed a final FFR of 0.85. It was post-dilated, and it got a couple of stents. So why am I showing this case? There are 3 lessons from this case. One, it's what is the data of IFR and FFR in patients with atrial fibrillation? 2, this was a revelation. What about nadir FFR versus average FFR? And 3, how to address these issues of IFR versus FFR discordance that may happen more commonly if we do both tests. I just have one quick slide on each issue. There's really not much published data on neither IFR or FFR with atrial fibrillation. There's actually this interview with Justin Davis, one of the investigators from the IFR studies, that he actually in the New England Journal of Medicine gets asked what's the reliability of IFR when you have irregular artery intervals and identifying the diastolic phase. And he shows this example and essentially says that the algorithm it's able to identify the diastolic phase reliably, and that this studies included all comers so that we can use such data reliably. Not much published that I could find on FFR. 2, and we have Dr. Seto sitting here in the front, it's this issue of either nadir versus average FFR and beat-to-beat variation. So after I went back and interrogated this waveform, you can see that the software, this is the Volcano software, and this happens with more commercial FFR softwares. It's actually a chapter from Dr. Kern and Dr. Cito. You can see here that our value and all information was in this nadir FFR with a value of 0.75. However, as you can see in the context of atrial fibrillation and beat-to-beat variation, you can really get FFRs all over the place. So as there's some discordance in the literature about this. Some people talk about single beat nadir FFR, but this Dr. Cito and other investigators have argued in this chapter, there's a value for doing average 3-beat FFR, which actually you can just change very easily on the software. Had we done that, which we didn't do in this case, if you get a 3-beat average FFR, you can see it's a value of 0.82. And it very well brings the question, would you have done just medical therapy alone? put that now into the context of the data of addressing IFR and FFR discordance. So this is a paper for Chris Cook in JACC Interventions just a few months ago. This is from the UK, in which they did IFR, FFR, and CFR in a number of cases. And when you look at patients that have non-obstructive coronary lesions or negative IFR and FFR, CFR, it's higher, and the discordant values, such as in our case, negative IFR with positive FFR, has a very similar pattern as those patients that have no significant disease and are not obstructed, whereas those that have significant lesions with significant FFR and IFR behaves more as those when IFR is positive. So this data would have suggested that had we believed the IFR, we would have potentially not stented anything and done medical therapy, which is actually very thought-provoking. Overall, the patient did well, symptoms resolved, she remained asymptomatic on follow-up and was maintaining anticoagulation and defibrillation and ethionopyridine without aspirin. But I think this brings to questions a lot of lessons about these issues of IFR and FFR. Thanks.
I think, Shami, your point is very well taken. I mean, with this case, is taking AFib out of the equation, with borderline numbers, and when you're struggling positive FFR, negative IFR, or the other way around, I mean, you have to go back and say, what is the patient here for? And are the symptoms real? Do you believe the symptoms? And that's really, the crux of the question.
Did you do aspirin for 3 months? No aspirin, just novel oral anticoagulant and the ethionopyridine. No aspirin.
Yeah, and like you said, we're even taking AFib out of the equation. When you throw that into the equation, you have questionable data, plus now you have triple therapy to contend with. And so I do think at the end of the day, this reminds all of us, when you get on the cath table, just make sure those, and this goes to the AUC as well, a lot more attention is being paid to that for good reason. It's to make sure that when they're on the table, we're intervening for the right reasons. We're not intervening because the FFR is 0.79 and we're not sure what those symptoms are. So that, I think, is probably the takeaway. And conversely, we're not letting them off at 0.81 when they're having recurrent episodes of what are classic angina and an abnormal stress test. All right, we'll move on to our next speaker. And between Chadi and Sheila Sahni, these two are, superstars of the future. And they've been involved with, I think, most of our major interventional meetings from their fellowships. She's going to present a case of an angulated, uncrossable RCA. And I want to thank everybody for your support. I have a flight to catch, so I'm going to head on, and Dr. Parikh and the panel will close out the session. Thank you.
Thank you. Thank you so much for having me. It's an absolute honor to present my best coronary case of the year. I'm an interventional cardiologist in New Jersey, and I have found a home to perform my high-risk procedures at Mount Sinai. I'm going to present to you a case of an uncrossable angulated RCA. My patient's a 59-year-old female. She's morbidly obese, hypertensive. She has known coronary artery disease, was previously revascularized to her LAD, and had a known lesion in her RCA that had been intervened upon, but it was unsuccessful. And she presented with worsening symptoms, both chest pain and dyspnea at rest, CCS class 3. And this is her left coronary system, and what you can appreciate in this caudal view as well as this cranial view is that her LAD system's intact and that the circ is intact and her LAD stent is widely patent. But her right coronary system is very tortuous, it's angulated, heavily calcified, and there's a total occlusion here in this RAO view that's really subtotal, almost TO'd in nature with good TIMI3 flow, but slow. So it's a very complex lesion. I performed this in New Jersey and took a step back and brought the patient to Sinai. And I think when I looked at the lesion, it was complex. It was severely tortuous, heavily calcified, angulated, and I knew that I was going to need certain crossing strategies, whether it was guideline or support microcatheter, a CTO toolbox, as well as a plaque modification technique for that degree of calcium. So we could stop there, but I could talk, at least let me show you what we planned for, because we knew we were going to intervene on the right. So here we are with the 6 French system, AL 0.75 guide. There's a fielder wire that's negotiating the proximal vessel and a fine cross that's waiting in the guide, ready to go. And what you can appreciate in the next field, in the next views, As we tried to advance the fine cross, it wouldn't negotiate the proximal lesion, and the guide is kicking back. So then we tried a guide liner to give the fine cross more pushability. The Fielder wire here is placed in the marginal, but what you can see is this was also unsuccessful. Both guide liner and guide catheter are pushing back, and the fine cross is unable to negotiate this proximal segment. So taking a step back now, what are our options for antegrade crossing? Dr. Parikh, should we open it up to the panel here?
Yeah, so Gautam, how do you manage this case now? You've got this sort of awkward shepherd's crook calcified right with a sort of an aneurysmal plaque to one side. Clearly the wire is preferentially in the acute marginal branch and nothing else will grow, and you cannot navigate a wire distally to get further purchase. They've tried, now you've got good guide support and you've got a guide liner, both of which have failed. Granted, the fine cross may not be the lowest profile, but what's next?
So yeah, Manish, thank you. I wasn't terribly happy with the choice of the fine cross. I mean, there are probably better microcatheters that might help. We'll grant that. One option might be to leave this wire there and come with a different system, different wire, different microcatheter, leaving this there to then try. You could try an anchor balloon technique in that marginal where it is. That would be another option. Finally, you may have to separate it and consider atherectomy of the proximal segment separately from the rest of the vessel. That may be another option as well.
So the anchor balloon isn't going to work here because you're not able to get a fine cross down on this vessel. You might be able to anchor on that conus branch up high up. That might be an option. But again, Sheila's chosen a 6 French system here, right? Okay, so again, so here, see a case like this, where it doesn't matter radial or femoral, you're going to need support. 6 French may work, but when it doesn't work, you're hoping for a bigger guide system. So, Dmitry, what are the other tips and tricks or options here?
Yeah, I think your point is very well taken. I think, this is something that failed before, and going into this, you have to really go in, be ready for battle. So I think, either doing it 7 French radial or potentially doing it as a femoral 7 or even 8, but 7 French probably would have been a potential solution with a Amplat's guide.
Okay, so let's talk a little bit about microcatheters. So Gautam mentioned fine cross. So we've got a whole host of microcatheters to choose from. I mean, there's 10 of them, okay? And your lab will not have all 10, and nor should they. But if you're going to do this, you need to have the lowest profile microcatheter, and there's a couple. The Turnpike LP is very, very good. The Corsair is very, very good. There's a Corsair Gold. And then there's also a lower profile than that, which doesn't have much push. But here I would have tried a Turnpike LP that could spin so that I could navigate that turn and then try to redirect my wire. The whole point here is to get the wire down the vertical part of the right and over. And once you do that, you'll be able to manage this right coronary. So it's the calcium and the tortuosity that's defeating you here. So, with everything else that was said by Gautam and Dmitry, that's the only other thing I would have tried, being a different system. Failure of fine cross doesn't mean that other microcatheters will fail.
I agree. Turnpike LP would have been a great choice for the torque in this angulation. The technique that was chosen, there were a few options, as you've heard from our panel. The technique that was chosen was definitely a strength of the institution that I was performing the case at. And so a very high-risk approach. The Fielder wire was exchanged for a rotofloppy. It remained in the RV marginal. And we went with a 125 burr and performed a short run of plaque modification for about 4 runs at 150 RPMs with the 125 burr. And this was our post-rotational atherectomy image. As you can see, there's slow flow down the vessel. And then in a parallel fashion, we advanced our fielder wire to allow for balloon angioplasty. And you can see we're still struggling at advancing this 2.0 by 12 balloon, but we were able to perform serial dilations of the proximal lesion. Post-balloon angioplasty, we had a contained dissection and poor antegrade flow. And we don't have a wire down the antegrade vessel. We don't have an antegrade wire down the vessel. Next, we went with a supercross, and for its success being a microcatheter in angulated vessels, and placed a Gaia second coronary wire that successfully went down the vessel into the distal segment. We exchanged, now our fine cross was able to advance over the proximal lesion into the distal vessel. We exchanged for a workhorse wire, performed serial balloon dilations with guideliner support, using both compliant and semi-compliant balloons. And our stent placement was assisted with balloon-assisted tracking for stent delivery using a guidezilla. And we were able to successfully place 2 long, large drug-eluting stents. And this was our final result. And some quick follow-up on the patient's done very well. It's about 8 weeks since the procedure and no longer having chest pain at rest or shortness of breath, but still quite sedentary. So just putting everything together, the crossing strategies that were used were rotational atherectomy to negotiate the proximal RCA lesion, a supercross microcatheter to negotiate the angulation, a Gaia second wire, and balloon-assisted tracking for stent delivery. I think that the take-home points are that there are many ways to approach a complex lesion like this that's calcified, angulated, tortuous. Systematic algorithmic thinking can be modified in the face of complex anatomy. Definitely the route that was chosen was extremely high risk and had a high chance of acute vessel closure. It was performed at a center that was going to be comfortable and prepared with the inability to open the vessel, and hemodynamic support was available. Thank you.
It's a very, very nice case. Many ways to do this. The supercross comes in several different angles, 120-degree being the most angulated, and it actually sits in the vessel angulated so that you could actually direct your wire when no other wire goes. There's a lot of other tips and tricks that could have been utilized here, but essentially the key of what Sheila did beautifully is sort of progress through this case step by step. And doing roto without a wire all the way distal is a little bit gutsy. Don't do this at home, but you were able to get away with it. So very, very nice. Great. Let's move on to our final case of the session. Dmitriy Feldman from Weill Cornell is going to talk about a case, cardiogenic shock and left main disease. Dmitry.
Thank you, Manish, and thank you to the panelists. This is truly an honor to speak here today. This is my best, or one of the best, and I guess one of the worst cases I've had this year. So this is a 63-year-old woman who was residing in a nursing home, blind, has traditional risk factors, hypertension, diabetes, end-stage renal disease, on dialysis, had bilateral amputation, so very poor effort tolerance, very poor functional status, presents to an outside hospital with nausea, vomiting, pneumonia, CHF. And then in that setting, she has a non-STEMI positive troponin of 5. She had no symptoms of angina at that time. So a decision was made to treat her medically, given all these multiple comorbidities. Unfortunately, in the next 2 days, she develops atrial fibrillation with rapid ventricular response. Her troponin goes up from 5 to 20. Her echo shows EF is actually pretty good with distal anterior wall and apical hypokinesis. She becomes progressively hypotensive over the next few days, and now she's transferred for a left heart cath. Here's her LV gram. As you'll appreciate, the LV function is not too bad. There is clear anterior and apical hypokinesis. The EDP was actually normal. And here's her coronary anatomy. So quite clearly, she has a distal severe left main disease that involves the ostial circumflex. And on this areocranial, you can appreciate that LAD is almost completely gone. There's a little bit of a trickle of flow. You can see on the cranial views, there's definitely a channel, but there's some competitive flow in the LAD territory with large diagonal filling as well. Here's the iliacaudal as well. You can appreciate there's a little bit of a competitive flow in the LAD territory. The RCA was actually pretty good, and you can also see that the septals are giving collaterals to that distal LAD territory. So we can discuss this now or at the end, but there are important clinical questions similar to the case that Dr. Parikh presented. What do we do now? Emergent PCI while patient's on the table? What technique? Should we go after the left main and circumflex? Should we save the LAD? Mechanical support for this patient? Should we consider urgent CT surgery? This is clearly a left main disease and surgical disease. Or should we consider medical therapy given all these comorbidities that she clearly has? I'll stop there, Manish.
Okay, good. No, so a terrific case. I mean, I feel your pain. Yader, how are you going to handle this case? What are you thinking about? You see a patient like this. You've got probably poor peripheral access, although we don't know, with bilateral amputations, and you've got essentially a subtotal LAD, which is collateralized, thank God. The right's open. A tight left main with a circ hanging on by a thread. So what are the decision-making steps here?
I think first, if the patient's stable and there's an opportunity for discussion, I think it's reasonable to not do this ad hoc on the table and to at least get a surgical evaluation and would be see what they opine. There will likely be a surgical turndown, but I think if the patient's stable and there's an opportunity for discussion about the different options of revascularization, I think that's always nice. If the patient has ongoing symptoms and ischemia, you have to go ad hoc, then certainly one must proceed. I think in this particular case, either radial or femoral, it's reasonable, and I think you probably want to have, you're probably going to wire both vessels. You want, I think, 7 French, either radial with a 7 French slender or a sheathless or femoral would be very reasonable. And with a normal EF, I guess I didn't hear whether there was an EDP, but with a normal EF, a normal EDP, I think you can do this without support and just go probably with a bifurcation technique, maybe a DK crush since it's distal left main. And definitely you want to use to wire that LAD that looked a little bit challenging. I think you want to bring a microcatheter to attempt different wires until you get into the true lumen. But I think you want support, you want microcatheters, and I don't think you need LV support personally.
Okay, so one more opinion. Gerrold, how are you going to manage this in your lab?
Gerrold wants me to answer for him, so I'll try. I think, the points you made are on point. It's complicated. There are probably 2 levels of bifurcation here if you consider that large first diagonal as well. While the LVEDP is fine and LV function is okay, I would be ready for mechanical support, which means having access, having all the gear ready, because things could go south real quick. But yeah, I would definitely wire circ and wire the LAD with microcatheter, but be prepared to do bifurcation stenting at both sites, the circ and the diagonal.
So the only thing I'm going to add to Tayo and the other present, opinion is that you have a very good option retrograde as well in the event that stuff happens. The issue here, the information you really need is what are the legs going to accommodate? And I think you need to be ready for everything. And either you could do femoral, radial, have radial access in case you need to go retrograde, and have some sort of mechanical support ready to go. Whether you use it or not will depend on the hemodynamics of the day, because my concern is you wire the left main to the circ and you're going to have abrupt closure. And then you've really got a big problem.
Manish, looking at the angiogram, if I may offer an unsolicited opinion here, the LAD and the distal left main also looks extremely calcified as well. There's a lot of contrast.
Yes.
There's a lot of black stuff you're seeing even before the dye starts filling the vessel. So I would also be mentally prepared for atherectomy. And if you want to atherectomize that, you might want to think about MCS as well. So, that's how the interplay of all of this kind of plays together as well.
Okay, so what did you do, Dmitry?
So these are all absolutely terrific points. So What we did is, like you said, we wanted to make sure we have good understanding of the femoral axis. So we did aortoiliac angiography, and actually the common femorals on both sides were of decent size, and the iliacs were okay. So we put a balloon pump in as we're asking the CT surgeons to consult on this, so that give us a little bit of time to decide on what to do. Of course, she's declined by the CT surgery, not surprising. But what we didn't expect is that now she suffers a PEA arrest a day later. And she's recovered pretty quickly, but now she's intubated, sedated on inotrope. She's developing worsening cardiogenic shock. Her lactate is rising, troponin's going up, and now ejection fraction globally reduced 25 to 30%. Exactly the situation we didn't want to see. So what now?
Well, I mean, at this point, if you don't do it, she's going to die. And the question is, are you going to allow her to die? And this is a conversation. You already said there's no family. And now she's already arrested. So the fact that she had the troponin that rose with AFib at rapid rates, our window was very small. And, I think that here, this is where you need to really partner with your surgical group and say, look, I need you to come down. I need you to look at this now, and I need to make a decision quickly.
Yeah.
And I think this waiting around in 24, 48 hours, this is what ends up happening. Now she's all ours.
Yeah. I think that's absolutely the point. And I think very frequently we do these cases, late and particularly in the middle of the night. And having that urgent or emergent CT surgery opinion is key to making these decisions. Because if we knew at that time that the surgery was not even on the table, then there's no point to waste the time.
I think the arrest also makes you want to ask the surgeons about ECMO as well. And that kind of.
So there was an important, obviously, and prolonged discussions with the family. Family wanted everything to be done, so we brought her back. We did a right heart cath, very important to understand the hemodynamics. Her pulmonary pressures were in the 50s, the wedge and the EDP is in the 20s. PA set 52, the index was 1.9. Clearly, still will need support if we're going to be tackling this patient. So here we went femoral, Impella CP on one side, 8 French guide on the other side. I wired LAD, the circumflex. First I'm dealing with the distal, mid to distal LAD, pre-dilate that, pre-dilate ostial LAD, distal left main, and as you can see on the bottom, now we got good flow in the LAD and the circumflex.
And
here after the...
What were your wires for the LAD, Dmitry, just for teaching purposes? What did you start with? So workhorse?
I started with run-through, and it actually went pretty smoothly.
Okay.
And then the circumflex, I think, just had BMW.
Okay.
So then after pre-dilating LAD, the ostium of the diag got pinched a little bit, so we pre-dilated that. And with the provisional stenting, I stented the mid-LAD, then kissed, and we're done with the LAD diagonal situation. Now it's just a simple, left main situation. So here, without talking too much about bifurcation lesions, we're dealing with the Medina 111. The angle is less than 70 degrees. So I think ideally, if we have time and we have the capability, the DK crush probably is the way to go here. So here's the way I did it. You can pre-dilate. You can use kissing balloons to pre-dilate. It's not a necessary step, but not a bad step to do it. This way you pre-dilate both ostial LAD and ostial circumflex. The first step is stenting the side branch. You want to protrude minimally about 1 to 2 millimeters into the left main and deploy your side branch stent. Step 2 is the balloon crush. So you crush the circumflex stent with a non-compliant balloon. Step 3 is the essential step. This is what separates the traditional crush from the DK crush so that you can actually improve your opposition and expansion near the carina, and you're avoiding that triple metallic stent struts at the ostium of the circumflex. So you want to rewire the side branch, preferably proximal access to the side branch, and first kissing with non-compliant balloons. This is the key step. Then, step number 5, you rewire hold on back. I think I skipped the stenting of the Main vessel is the step 4. I use the Synergy stents here, but you can use any stents you want. Step number 5, you rewire the side branch, preferably from the proximal main vessel stent cell, sequential post-dilatation of the side branch, main vessel, and importantly, final kissing with non-compliant balloon at very high atmospheres. You're not done quite yet. Proximal optimization with a short non-compliant balloon. I didn't mention, but we did IVUS before so that we could size the stents in the left main appropriately. We IVUS afterwards to make sure that we expanded and opposed the stents nicely in the left main as well as in the ostia of the LAD and circumflex. It's clear from the data, clinical data as well as anatomical data, that the two-step technique, two-step kissing technique achieves better stent expansion and opposition, particularly at the ostial circumflex territory. And this is our final result. As you can see, well-expanded stents in the left main, ostial circumflex, and ostial LAD. And from the cardiac standpoint, patient did quite well. We removed the impeller. We put a balloon pump at the end of the case. The ejection fraction recovered over the next few days. Inotrope vasopressors were removed. But the patient had a very prolonged hospital course. It was complicated by pancolitis. She wasn't able to take PO anymore. We had to put her on Cangalor drip, pneumonia, sepsis, sacral wounds, and importantly, very poor neurological recovery, partly from that original cardiac arrest. So she had anoxic brain injury, long discussions with family, and after several weeks in the CCU, patient was made DNR. So teaching points, and we can discuss this with the panel. As we mentioned, if we're going to go in an invasive route, early transfer, early angiography is key, and then early PCI as well, not waiting for the surgeons to decline if we know that the patient is probably going to be declined. Early mechanical support. I think if we know we're going to treat the bifurcation, and DK crush is probably the best driven data option, particularly for this anatomical subset. There are a couple of technical teaching points. First kiss, where you want to cross the proximal struts of crush stent. The second kiss, where you want to cross with the wire in the proximal to mid struts. Alternative inflation of the side branch before each kiss with non-compliant kissing balloons at very high atmospheres. POT to improve the main vessel strut opposition, and post-procedural IVUS or OCT, whichever one you prefer, but it's the key to also improving anatomically and clinically important results. Thank you.
So a absolute flawless technical case with an unfortunate event and outcome. And again, I guess that window of time, which was lost, unfortunately, is really, ultimately the demise, although, she was sick, period. So, but you absolutely performed that flawlessly technically, and I think this is what we are able to do with some of the tools we have and the techniques we have and some of the skill sets that we've obtained over time. And I think the DK crush was absolutely the right thing to do there, and it was done perfectly. All right, so we have about 4 minutes. Let's just go down the panel. A couple of one-line teaching points from these best cases. These are terrific cases. Sheila?
Well, I think the cases were absolutely excellent and really captured the breadth of dealing with high-risk lesions as well as conundrums of the Cath Lab. But really, I'd like to highlight Chadi's case of the left main perforation, because we can talk about doing left main and atherectomy, but being prepared and knowing what can happen when you use these devices, whether it was induced by the guide or poor prep, or releasing the tension from atherectomy to make sure that whatever device you're using doesn't dive in, I think was really key. And then how to manage a left main perforation, what tamponading a balloon in the left main looks like. I think that was a real highlight of this session.
Okay, Chadi, what?
Yeah, I enjoyed we elaborated multiple times on DK crush and when to use this technique and what kind of wire Dmitriy kind of illustrated nicely. I usually, when we prepare for these cases, I have to open the BiFid app. I don't know if anybody had it. It's for bifurcation, and I have to go step by step, but you simplify it really nicely in your case because there's too many steps, too many wires back and forth. So if you lose one step, you lose the purpose of the technique. But it was a well-done technique and also a nice case and results.
Yader?
I think it's, medicine is hard, and those two cases that had flawless, excellent technical skill to angiographically have a great result, but patients ultimately succumbed to the disease and had a negative outcome. It's very humbling. I recently had a case as well like that, like a 2 or 3 hour complicant STEMI, like subtotal right. 3 hours of a case would get a great result, and afterwards, after a few days in the ICU, palliative care team on ICU, essentially pulled the plug and went to hospice, and the patient died as well. So it's really humbling that it takes a lot of hard work to identify, define goals of care and define prognosis of patients, and define that if we're going to move forward with these very, very complex cases, that everything will be done as much as we can to make sure that we get the best outcome possible. It's hard, but I think it's a lesson to that as well.
All right, Gautam and Tayo.
Yeah, again, just excellent cases, a great session. I think what I took away most from this was how quickly things can change for us in the Cath Lab, and that we've absolutely got to be well prepared with all the available tools that are out there. It is a big investment, for each lab, but, as you can see, very necessary for some of these cases.
I think the take home here on a couple of these cases is to make early aggressive decisions, particularly when you have severe multi-vessel left main anatomy, you have severely depressed LV function, you have borderline systemic pressures, and then congestive heart failure. In these patients, I think move early to mechanical support is critical, and not to tally, not to dilly-dally around and get right with the revascularization procedure.
Good. So I think that we've really had a terrific session. I think this is really all about patient care, technical expertise, decision-making, and being a full physician. And I applaud all the presenters. And with that, we'll take any questions if anybody has, but otherwise we will close the session. Thank you very much.